baby during his a small baby time. So it's under care of Dr. Sundra lah, from the opposite hospital, Thompson. So currently, he has not given any treatment plan yet. It's only follow-up. The last visit was November 2024. So Mr. D is wearing spectacles since 8 months old, when he was a baby still. So currently, spectacle age is since November 2014, 24. So VA consider okay, according to patient, still clear. No allergies reported, medical condition or medications. So, and as well, there's no other ocular condition and medication from their family. So this is a purely born with the optical atrophy. So the purpose of visiting clinic today is to seek for opinion from our low vision clinic because it's referring by Dr. Sundra. So currently he has not applied to any the OCU registration, and also no other particular reason of visiting this because of the referral from Dr. Sundra. So after the history taking, so we have discovered more about his task-related history, which he mostly sitting in front of the class during school, so just at the front line. So often watch TV, but so far there's no complaint on blurry and all. So and as well, he staying indoor mostly compared to spending time outdoor because of the not confident expo outside. So can he be independent with near tasks? Example, he's doing homework himself, dress up, keeping toys, read as well. So he is a reader. He loves books, reading books, prefer a large font printed. So their parents also prepare the printed books for him. So can differentiate color because he do jogging as well sometimes. So he's a good social interaction with the same age among the same age. When he is out, he always accompanied the parents. So he also claims to have a bit of photophobia to a complex at night. So this is the task related that we through the interview with the parents.
Good morning, Miss Indira and fellow classmates. Optic atrophy. Optic atrophy refers to the damage to the optic nerve and leads to degeneration or loss of the nerve fibers, resulting in the pale optic disc when viewed with an ophthalmoscope. This condition impairs the transmission of visual signals from the eye to the brain, can cause vision loss, decreased brightness, difficulty with color visions, reduced peripheral vision, and reduced contrast sensitivity. Next. The assessment. The assessment of the present RX is right eye is minus 5.25 short-sighted. The left eye is minus 50 and with astigmatism 300, with the root astigmatism 170. The left eye is a better seeing eyes. The vision acuity for the distant, the right eye is 1.26 logMAR at 2 meters. Pinhole, no improvement. The vision acuity is 6/109. Whereby the left eye is 0.76 logMAR at 4 meters. Pinhole, no improvement. VA is 6/35. Both eyes is 0.74 logMAR at 4 meters with 6/33 VA. Near one is a right eye 6.3 M at 26.5 cm. Left eye is 4.0 M at 21 cm. Both eyes 5 M at 25 cm. The reading speed is 28 words per minute. The visual field test for Jerome for picture 1, the right eye confirm of optic atrophy. The left eye is small yellow lesion found on macula. Next. The Jerome screen chart tested the left eye visual field loss on the nasal inferior quadrant during the Jerome screening. Next. The oscillative test for the right eye with pure optic disc vessel attenuations. Next. Picture number 3, the left eye with small yellow lesion on macula on the patient left eye. Next. Okay, thank you.
Currently, the patient is not any optical device using now, but the patient need a larger font size, high contrast print for the schoolwork, and the patient need longer examination hour, longer deadline for the housework or assignment. Now, for this visit, is not any device is being performed, but we found that it's actually for the patient when using the textbook require N8 font size. It means, but the patient is now only with the N32. So, which means is that patient need 4 times magnifier. This is suggest to the prescribed stand magnifier for study. Next, please. So our diagnosis is for right eye is an optic atrophy, left eye is a yellow spot on macula, caused visual field defect on nasal inferior quadrant. Next, please. For the management and rehab, we advise the patient on the OKU card application and advise the parents to discuss with the school teacher only after the recommendation letters is issued. So the recommendation is including larger font size, high contrast print for the schoolwork, and longer examination hour, longer deadline for the household and assignment. And we advise the patient to come again 1 year to monitor on the progression on the visual field and the macular condition.
Okay, discussions. So we recap for this case. Duration of the condition and the onset, the low vision sight since a 4-month-old baby affected both eye. Stability of a condition and the difference between eye, blur of vision, right eye more than the left eye, distance and near, condition getting better. Patient knowledge of condition and the prognosis. Optic atrophy and the macular lesion informed by doctor are no futures vision. Ongoing hospital monitoring and treatments, care by Dr. Sundra, TMC Hospital. Last follow-up is November 2024. No treatment given. Register status, not registered under OKU, and receive support from any of community groups. Education and employment, study in a primary government school, sitting in front of the classes and doing good. Present at and spectacle, current spectacle wearing since November 24 by Dr. Sundar RX and started wear since 8 months old baby. General health is health and no medication history, no other ocular condition within the family. Why did the patient make appointment? To get the visions advice and the referral letter for school and to register under OKU. So we discussed about the assessment was not conducted. Color vision test, the patient can differentiate colors and draw, suggests no obvious issue. Although not essential, the testing color vision would still be useful since optic atrophy can affect color perception. Pupil test, useful for diagnosing the optic atrophy, but not necessarily here as the diagnosis has already been made. Keratometry and topography can be done at the next visit to better understanding the high astigmatism in the left eye, through not urgent now. Retinoscopy and the subjective refraction, not done because the pinhole did not improve the visions and the current glasses are only 3 months old. A scan, not needed as it does not related to the current management. Tonometry, recommended using the eye care device to screen for possible optic nerve damage from glaucoma. Amsler grid test, helpful for checking central vision problems, especially since the yellow lesion in the left eye may involve the macula. It can detect issues like wavy visions or the blind spot. Contrast sensitivity tests, good for finding sub-vision problem that regular eye tests might miss, especially if the macula is affected by the yellow lesion. For the management, a 6 months follow-up is recommended instead of 1 year, as the patient vision is still developing. Longer gap may delay care. Also, the current glasses were only given 3 months ago. Regular checkup help ensure the best corrections during this important stage. Since the patient is 7 years old now, and the patient can be informed about the Low Vision Act, like stand magnifier, to help with the near tasks such as the reading, like the Lian just now have told about the stand magnifier. A trial of the low vision device can be planned for the next visit. And the patient was referred by the Dr. Sundar to get a school recommendation letter and help with the OKU application process. Thank you. That's all our presentation today.
Okay, thank you for the presentation. Okay, okay, we'll take a 5 minutes break. Then everybody, now only coming in. Okay, then everyone may write down your questions and then we will start the discussion. Can we do that? Can, huh? Okay, we'll take a 5 minutes break, then we'll continue.
Okay.
有什么问题要问吗？
来，什么问题？要看 recap。
要看出来。
那些是这么会跑掉，看到我也不知道这么是不是我先换去不同电池。你看在那个 finding assessment 那边，然后左右的那些字好像 off 掉了。
哦，你的那个 assessment 哦，对啊。
哦，对了，这么会好像那个 space 跑到这样远去了。
你在你那边不会咩？
会我
也是走啊，我都看得出来是走啊。
看我这边是没有，不懂是不是因为你是用 MacBook 开的？我这边没有 ，maybe 它有一些version 上的东西，它好像我们用那个slide 那些也是会不难的。你 Excel 丢下去的时候，它也会跑。
我今天开不到车，
你们有什么
也没有，
问题要问？
我开不到车。
你们有什么问题要问吗？
有什么问题要问吗？
你们有什么问题要问先，然后我们等一下可以。
你先大概讲一下你想问的问题吧。
问一下，你们有发现到什么问题？
你不要学我这个问题。
你们发现到什么问题？
厉害
讲。我也问我什么问题？
其实这个我是想问的。
什么问题？因为就这样咯。
先讲话。
其实他其实说他叫我们做 case revise 是说让我们去发现问题嘛。
他其实是要我们给你是说 Miss 只要叫我们做这个 case discussion 啊？
去讨论一些没有被发现的问题，或者漏了什么，或者
没有啦，他
我
们都
们在最下面最下面那边呢，下面就是有很多 test，其实它这个有很多 test 没有做。
他 recap 到完全部了咯。
哇，这个类很好吃呀！
啊，你别这样，我还没送鞋，我听到你讲送鞋。
他的 left eye 是什么？他的 right eye 是 atrophy 嘛？哦。
你问什么面？
atrophy， right
然
side
后你说他 left eye 有什么东西啊？什么 yellow 什么？
yellow
Yellow
lesion
啊？看一下
yellow lesion
啊，这个 yellow lesion 什么来的？
好，
啊？
在他们的 diagnosis 里面没有写明它是什么东西，它只是写 yellow lesion，它也没有写是 bruising 或者是 ischemic。
Yong Hao, are you the one controlling the slide? I know while others taking break, I just want you to go to one slide, the discussion slide, because I missed out.
OK，
Okay, just hold on first, huh? Okay, next. Next. Okay, slide number 20. Okay, you all may continue. Okay, we'll be back after 2 minutes.
OK，
So can you see the yellow light? What is the yellow light?
yellow light 啊，
It is a reflection only or what?
this is not the real one. This is from the internet.
Oh.
So the photo source from internet illustration purpose.
Yeah. I think the real one is with the Segi OCT lah.
So you 不得到 any 啦 What is the problem of this 啊
No, I think Miss Indira go dig the file now.
Yeah.
Okay. So optics atrophy, this is only happen on the right eye, right? So is any the risk like bilateral? The other eye had to take care?
So far, there's no sign of
No, I mean
having
need
this.
to be careful. Need to be careful not. Usually monocular or bilateral. I mean the chances. Risk factor 啦。
没有这个 risk，讲一定会，一定会
找了啦，
找了。它有几种原因影响这个 optic atrophy 啦，有可能是来他们的ischemic 就是 neuropathy 咯，可能是 tumor， 或者它是trauma 也是可能，然后或者是它是那个optic neuritis 啊，或者是它有很多次的那个 sclerosis， 就是sclera 有 inflammation， 它也是会这样子。
去你那个 slide， 刚才那个
哪一个
atrophy 的
slide？atrophy 的 slide
啊，等于在前面的啊，这个是吗 ？Can cause， 这是说你是说，
其实是 damage 那个
can causes 这个吗 ？But 你没有讲到说有查到说 caused by 什么了？这是 will cause。The other one is caused by 4个月就发现到了。
Sorry 啊，打断一下。这个应该不是重点吧？
这个是 Kevin 要懂吗？
我问一下吧。
我们是讨论 low vision 嘛？对啊，他要懂这个 case 嘛？是没有错的。
4岁
我是
或
说了，我是说那个。
哎，没有，是说现在是4岁嘛，但是大人也是会有这个问题啊。然后我知道他的原因，什么原因导致会有这种病症？
我们
不是 low vision 才会有 这个 optic atrophy 嘛？对啊，
这个
对它主要的原
optic
因
atrophy 是会 reversible 的嘛？
不会啊，这个 yes。
不会，
这个呢，它是 congenital 来的，所以它很有可能是在它 during 怀孕的时候，
我觉得
它是
已经
lack oxygen to the eyes 啊。
那我直接是说没有血，
免疫啊。
我们
就是
要
说没
more
有血
for 我们要 more follow clinic 的方向啊。
对啊，
我东西问，
来，
刚才听你们讲话，因为我刚才在车上。刚才你念的时候有念到他影响到他什么嘛？哈，
有啊，
这个
这个有写
vision
vision loss,
我
decreased blindness, difficulty with color vision, reduced peripheral
不
vision。
是哦，他平时
这个
的
是
activity 哦，
这个是 optic atrophy 的。
因为我看不到，我没有看那个你的 slide，我只是用听罢了，在车上。
so far 没有影响到任何他生活上的东西，
没有啊，
只是在上课的时候，他会比较慢一点啊，因为他其实 VA 不会 low 到那种很 low 的那种啊。
可以回去
知道，因为他这个，
我听到刚才有一个6 over 100多是吗？我好像听到
109，
那个还不差。
因为他是 one eye
那边嘛，
他是 one eye 那个会比较差一点。
去那个
然后另外一个
回去 prescription 那边。
vision
另外一个
assessment
6 over 30 something 是吧？好像 Steven 才念到是吗？我好像听到。
可以回去 vision assessment 嘛
6 over 35。
啊，对。
这个不是 assessment 哦。
啊，是 OK。哦，
所以他用一只眼睛看东西啦，所以他觉得没有 complain 吧？
因为从这边刚才我听，好像没有讲到有什么 specific activity 它是有问题的哦。
A lot of discussion, without me. Okay, shall we start? Anybody wants to start first? I mean, you have to start first, then only I can.
Okay.
Anybody wants to comment?
Just
Ken.
Just I'm asking, based on just on that one, the VA. Back, go. This one. The left is better seeing eye, and right side is 6 over 100 something, right? Then what is the specific activity most affected by the vision? I think never mentioned, only in the class cannot see, right?
Difficulty.
And
according to the history taking, you continue first, yeah.
The group member, anyone can answer, not only Young Hao, but anybody can answer, Benjamin's question.
Can go back for history, history taking. That's history taking. Watch TV.
The only patient have said is prefer the large font printed.
I think maybe can ask what is a watch TV distance?
Any activity, outdoor activity. So there's a staying indoor and more than outdoor activities.
Scared of expo.
Scared of explore outside because of light sensitivity or what? Scared of
because
explore outside.
This patient actually is a bit shy.
Shy.
So yes. I think it's low esteem.
But there's a possibility scared of
normal school, right?
Normal. This patient actually experienced photophobia to the bright light.
So did he use sunglasses at school?
No, he only mentioned during night use photophobia during night.
So the magnifier glass
for
using a magnifier glass, is it stand one?
Not
magnifying
using
No.
any particular aids yet. It's just that we suggest he can consider the magnifier, send magnifier for study, because
Oh.
according to the near reading result, it doesn't seem to be applied to the textbook fonts needed.
That means magnifier glasses is non-illuminated lah.
We can
Photophobia, is it?
consider that because we did not try during the clinic. So this is the data that we got it from the clinician. So we just enhance a little bit and give our advice. So we say that we will suggest to have a magnifying glasses when it comes to the study.
Any questions
In
from
your
others?
management, you say that your management there, you mentioned about the exam time, you need longer time. Miss Indira, I want to check whether for OKU people like or low vision, do they have any specific calculation of how long the examination time or any standard timetable or whatsoever? Yeah.
Oh, okay. That one, the calculation is actually not done by us because it is done by the Ministry of Education. They have a team for it, okay, where they will do the calculation. Basically, if let's say they are considered to be visually impaired and they need the extension of hours, right? It is not like 1 hour paper, they get 2 hours to answer questions. No, maybe 1 hour, 10 minutes or 1 hour, 15 minutes only. So it is just by a few percentage only. So there is no such thing that if let's say the VA is like N32, they get 10 minutes, and 8 they get, if let's say N32, 15 minutes, and 24 is 10 minutes, not like that. If let's say you're visually impaired and you cannot read and write, you write, I mean, that patient writes slowly, right? They get the similar time only.
Okay.
So they already fixed that lah. Okay, that one, they upgrade by time to time lah. So that one, only Ministry of Education knows. We don't know.
Understand. Thank you.
Okay.
Does the left eye well progression worse?
Yes, that's why we need to monitor because it's affecting his macula. Although it's not status, it's what the lesion all about. But I believe the CEGI OCT has better pictures on there. This is I capture from the internet sourcing to show as an illustration.
So there is no information based on the case file, huh? It's not recorded.
No, it's not
Okay,
recorded.
it's okay. If not now record, then just say that it is not recorded. Nobody else got question.
It also means family history, is it? Optic atrophy, is it can be hereditary or not?
Can.
Patient is can.
Can. So family history is not covered. But in your discussion, you write slide number 20. Did you? Slide number 20.
See the recap.
Patient has
written.
Patient.
Okay. Others?
Can be
Why I got so many
or
questions? You all don't have question one.
you are here, then no question.
Even though I know the case, also I got so many questions, but you all never ask any questions. Anyway, Yong Hao, what is the patient's name? Huh?
Okay, moment. It's a Desmond Mutu Maran.
Oh, Deshwan. Okay. Any more questions? Hey, many people are not talking, huh? Hey, got marks. Okay, if let's say no question, I will start first. Maybe you will have questions after IS, huh? Okay, can you go to your task-related history slide? It's a short case, lah. We will have a short discussion, but at least will be helpful. Are you clicking it? Because I see your slides are not moving. Okay.
Yeah.
Now I can see your cursor. Okay. Love reading books. Okay, this one, when it comes to low vision patients, right, you have to be very specific on what kind of books they read. Okay, books, they have many types. Okay, like, okay, since you are talking about 7-year-old kid, right, the books can come with only wordings. Okay, another type of books is can be pictures with words. Okay, and another kind is like the comic version. So they will have characters and then they will have a bubble and then, they read from it. Okay. So all this need to be asked in detail. Okay. Why we need to ask in detail is because we want to know exactly what the kid is reading. Like if let's say it's only wording, right? Okay. The type of management that we are going to give them, it's going to be easier for us. If let's say you're going to prescribe them with magnifier, okay, it's going to be very easy. Even the choice of the magnifier also is going to be easier. For example, if let's say they are reading text only, only text kind of book, right? We have this magnifier, that one, it's like a semi-cylindrical one. It's like a bar magnifier. It's very long. You can have, it looks like a pencil, but slightly thicker than pencil, like a ruler but thicker magnifier. Okay, so when you put on the reading material, then the whole line will be visible and magnified to the patient. Okay, but when if let's say they are reading something like, with picture and also the text together, right, that magnifier is not going to be helpful. It's even worse if let's say they read comic books. So that is the reason why this one point with detailing will help us in the management. Okay, so this could have been mentioned in your discussion, that maybe you can have like task related history. What are additional question that can be asked? You could have that point. Okay. Okay, next is, okay, go to your VA measurements, like the results.
Sorry, Miss Indira.
Mm.
So, before we go to other slide, is that just now that the patient mentioned that always accompanied by parents? So, can I ask, like, is that patients like got risk like a fall before or not? Is that possible for me to ask this one?
Sorry, fall before. Oh, can. Because that actually gives a clue whether the peripheral vision is already start affecting them or not. If let's say
Yes. Because I'm just wondering why always like accompanied by patients' parents.
Yes, because this boy, right? Okay, this boy I met in Oasis first. Okay, so this boy is actually very shy. He doesn't even talk to me. Okay, when he look at me, also he will actually, keep his head low. Okay, and his mother said he's actually very shy, and also whenever he goes out, right, there's two things. It could be behavior, because I asked this question in OISIS, but then when student ask, they never ask this question in our clinic. Okay, so when I asked the mother, you are always accompanying him. Yes, 7-year-old kid, obviously, the parents will accompany them. So I say, when you go to playground or you go to, places where he can play by himself, like kids, right? When you bring them to playground, they do look for parents. They can just go, play slides, play swing and all that. So I asked the mother, does he do that? The mother said no. Then I asked the mother, is it because of the vision or is it because he's very shy? Then the mother said she is also very confused with that. Okay, I'm not sure whether he's shy, because the mother said the father is also the same character, very shy person. Okay, doesn't talk to people, that kind of person. So she also doubt. Then I told her to monitor that. Okay, is it because his vision is poor, or is it because he's very shy to do things by himself? He's very depending on the mother because he doesn't feel comfortable doing independently. So in the next follow-up only, we will know whether it's because of the behavior or is it because of the vision. But when I asked the mother whether he trip and fall or not, According to the mother, familiar places, no. And when go to unfamiliar places, because he's accompanied by, her or the father, so there is no such incident has happened lah. Okay, so she doesn't know whether that will happen if, let's say, he independently do something or not. So this question is covered, but it's not written in the report lah, because I asked this in in other places. But that's a good point. Good point. Thank you. Yeah.
Thank you.
Okay. Okay, VA. Okay, VA number 1 is the recording is, I think the students have written like this. Okay, 1.26 logma at 2 meter, no need to write because you already converted the value. That means the correcting factor is already added. For 4 meter chart measurement, you no need to record the distance. Only 3 meter chart that you need to record the assessment. To record the distance. Okay. So this one, I just want to, correct that. Okay. Now we will have a discussion. Go to your slide number 10.
10.
Okay. Based on this, you have written that left eye visual field loss on nasal inferior quadrant during Jerem screening. So, in that patient, which part of the eye that is actually affected? When he see, which side is actually affected? Anybody can answer, not only the group members. Anyone can answer. You can attempt.
Temporal superior.
Temporal superior. Okay. Other people? Anybody has a different answer?
Agree with that.
Okay.
Yes, agree.
I'll give other
Yes,
people.
agree also. Yeah.
Yes, agree. Opposite
Is
side.
that
Right.
Yes,
opposite
agree.
side? Is that so? Nobody is not agreeing with not disagreeing, huh? Because here it's written as, I don't know whether you are explaining the field loss or you were explaining the loss in the patient. Okay, so that's why I had to question this slide. So if you say temporal and superior of left eye.
Superior temple.
Superior temple. So basically this side is actually affected lah when patient view. Okay. Sorry, this is nasal. This side.
But then regarding to this, I have one questions. Because due to what patient see will be in the inferior quadrant, right? Supposedly, the superior quadrant still can able to detect some of the what we call the blind spot. Why doesn't they record the blind spot as well?
Maybe okay, number 1, we don't know whether this is fully reliable or not. He's just 7 years old.
Correct.
If you see, another thing that is not reported here, I have another question here. If you see, it's written here, patient actually see nystagmus. Yes, that was not reported. So I thought you would have discussed this nystagmus, why he has nystagmus when, eye is occluded, but it was not discussed. That's my another question that I had lah. Okay, so one is the eye was having nystagmus. So we are not very sure, what is the problem that the kid is actually facing. Okay. So the blind spot missing maybe because of, the scotoma that the patient is having also, this is left eye, fall on the same place. Okay. Okay. One thing, okay. When I asked, everybody agreed with that. Okay. But my question was, when in the Jerem patients see the nasal inferior quadrant is problem, where the scotoma will be located. And everybody said, I'm going back to the first question. Everybody say that the patient should see the scotoma at temporal superior. Right? Betul ke?
No,
No.
no. It's the nerve damage. Right.
It's a
Yes.
damage showing at the retina.
Yes. The damage on the retina is the one opposite to the germ. Okay,
Yeah, this is
whatever
what we
that is.
answered.
Yes, just want to correct the understanding only. Yeah, I understand what you meant. But what patients see in germ, that is where the location of the scotoma that they will have. But what is happening at the back of the eye is the opposite side. Got it? So try, just trying to align the understanding lah. Because my question was, where do patients see scotoma? And then you are answering the other one. But in mind, you are correct lah. Okay? So whatever that patient see in the germ or emsler is represents the location of the exact location of where they see the problem is. But the interpretation, when we want to explain where the defect is, that comes the opposite one. Okay, the inferior becomes superior, temporal become lesser. Okay. So this one I'm done. Okay, why nystagmus when the eye is closed? One eye is closed. Which eye is closed? Huh? This is left eye. Correct, Yong Hao? Left eye, yeah.
Left eye.
Yeah,
Still
yes,
on the
this
left.
is left eye. Yeah, OS. Okay, left eye. So when the right eye is occluded, the left eye is actually having nystagmus, correct? Am I
It's not
understanding it
sticker.
correct? Then here in the
It's
germ screen. Then
There's small
Baracus
little notes there.
it's written as better seeing eye and large. I think it's a
largest nystagmus. The other eye they never do, is it? You know? The other eye tak ada.
No
No
reference on
record.
the other eyes.
Left eye only.
And not mention why never do, because I forgot already the case.
Actually, the case are quite empty. I
Yeah,
thought
that's
it's just
right.
a simple interview. That's why we're trying to make this more complete. So
Actually,
we add on.
this is because they came only to do germ. Because there in OIC started germ. And we cannot do free visual field. And plus he's having nystagmus. So he was referred here by me because we want to know whether there is any visual field defect or not for him because it is optic atrophy. So that if we monitor him now, after 6 months, when we make another appointment to actually check him again, then we will see, if let's say there is a enlargement in the scotoma that he's having currently, it shows the progression. Okay, because VA, based on what Dr. Sundar sent to me, and when I measured him in OISIS, it's similar. So based on VA, we don't see any progression. So the plan is to monitor the visual field. That's why we did this. Okay.
Thinking to make an appointment with him during our weeks, see what we can discover more from
correct
the initial.
Yes. So
he's quite visited quite recent. I think it's quite possible to show up.
Yeah. You will be coming back on August. When are you coming back?
July.
July.
It should be about the times because
I think
February.
can because our idea is to monitor the progression. So maybe you can make appointment of this patient. You got the number, right? The parent's number.
Yeah, I got the number.
You just say that you're calling from Miss Indira Clinic from Segi Eye Care that we want to monitor. It's almost 6 months. Boleh. Okay.
So
where
is
were
the
we?
contrastivity test is side by side with this one?
Yes, because the one because I
here didn't do contrastivity also.
yeah. We will do it because the other day is only for the Jerem, because Jerem itself took very long for us because he didn't respond to it, and then we had to take break just to get this.
For low vision patient, normally contrastivity is very important, right?
Very important. Yes,
Okay.
must do.
Okay, thank you.
Okay. So he's having nasal inferior visual defect. Yeah, missed to discuss about the nystagmus. Okay, why nystagmus when the left eye is the better seeing eye? Why do you think this patient is having nystagmus?
according to the info that I had, because of during the develop the early infancy, the visual system that does not receive the proper inputs in the signal, so that will lead to a sensory nystagmus. So this is because due to the poor vision signal from the retina and optic nerve. So that is the only way can explain that it's also there are few statement shows that this optic atrophy would actually lead to nystagmus. High chances of this nystagmus.
Correct. Okay, because the eye was not fully developed because he born with the problem. Okay, because of the lack of development of the vision system in the eye, that could lead to the nystagmus. Okay, good.
Miss Indira,
Okay,
why
yes.
the first history, I mean like low vision patients, why we cannot take photo of their eye or draw their eyes so that everyone can see the record, have
Actually,
more idea about the person look like and the
okay.
eye, cornea, everything. Yeah.
I mean, you can. Okay, this is you can take picture in slit lamp. Okay, or you can take only the picture of the eye, but that one also need consent from the patient and also the parents. Okay, because sensitive lah. If let's say it's only the eye, then can lah, but not the whole face. So that one need consent. But when you take picture in slit lamp, no issues because it's our recording. So, but if let's say you want to take only the eye, right, can be taken. Okay, so usually the parents they don't mind. But if let's say with full face, then cannot lah. Boleh je, can. Okay, okay. Okay, can you go to somewhere you the written about the font size of the book, and then I don't know whether it's calculation for magnification or something.
Yeah, there's a calculation under optical the visual
Can you
aids.
go? Can you go to that slide?
Yeah, this one.
Correct. Okay, if you see the low vision device trials, the textbook require an N8 form. Okay, when it comes to 10 years old, you have to find out whether, 7 years old, you have to find out whether they need N8 or not. Supposed to be bigger than that. The font size is about N10. I think by the age of 9, something only, their font size gets smaller. Okay, so this one need to be very careful. The easiest way is when they come for appointment, usually we'll ask them to bring their school textbook. One book, one or two books lah. So we will be able to have idea what is the font size by comparing to the VA chart that we have. And then when we make calculation, it will be more accurate rather than what we check in Google or what we imagine. Okay, and different age has different text font. Okay, so maybe when you make appointment for him, maybe can ask the parents to bring one or two textbooks so that we can have idea how big or how small is it. Can I? Okay. Small case, but okay. This is the management, is it? Where's the management part? Or go to the funders picture, the OCT first. I missed to read something there. This is his one.
No, this one is a photo source from internet for just
That's
picture
why.
purpose only.
Okay, because we didn't take picture, if I'm mistaken.
Just
Okay,
want
the
to show
second.
how the atrophy looks like. It's a
Okay.
pale optic disc.
So the second one also like that, is it?
Correct.
The okay, go to slide number 12. This one is not his picture, right?
His picture. I just based on this yellow listen and look into the internet source. What are the relevant one?
Oh, you didn't access the OCT result, is it?
No. We were snapping the picture, and then after that we chow already. We did not manage to access to the OCT.
Okay. So this left eye with small yellow lesion on macula was mentioned in the recording form, is it?
Recording form, yes.
Okay,
Only that
okay.
few words simple.
Okay. Okay. So this left eye and right eye has two different complications for this patient. Okay, so it's a general question. What kind of problems that the patient would face related to right eye, and what kind of problems the patient would face related to left eye complications that he has? Anybody can answer. Take time, think. You look at right eye problem, right eye VA, right eye visual field result, right eye OCT and fundus result, and then the left eye.
If possible to have a visual field defect lah.
Okay, what kind? Peripheral or central?
Peripheral.
Central. Peripheral.
Peripheral.
Okay, peripheral. Okay.
Right eye should be
Nothing.
Right eye, no problem.
It
right
might
eye.
be
What?
it might be no issue because the brain will be matching filling up the images because one eye is quite okay, just only left eye is a vision loss a little part only. But I want to ask like the very general question as well. The first intention beside Dr. Sundra asking for register for the OKU, the main complaint from the patient will be what reason?
There's no specific reason. It just came for they want to seek for further opinion during
What I
the
mean
day.
is not from Segi side because Miss Indira just now say is going to a meeting at Oasis, right? The reason going to Oasis will be
similar to what Yang Hao said. Basically, patient was actually monitored by Dr. Sundar all this while, and Dr. Sundar said, I cannot do anything from my side. Indra, maybe you want to try something or not and see how it can help because he still can cope up in the school, so no issues and all that. So he
correct.
sent me, just to see what I can do. So the parents came to me to get opinion on what's happening to his eye. Is there anything that can be helped or not? Because complaint wise, he has no much complaint because he's so used to the lifestyle that he has. Okay, not able to read that N8 and all that. So he's so used to it, and then so no much complaints. So when he came to Oasis, so and also at this age, right, I don't prescribe magnifiers. Okay, because if let's say give magnifiers, right, it's going to complicate his life. I rather prefer him to use large printed materials and all that. That will be more helpful for him rather than prescribing a magnifier with a smaller field of view that is going to complicate his life more. So that is the reason why I don't go into the magnifier on the first visit, even in Segi also. So we just want to monitor the progression first. After that, wait for him to complain that saying that, oh, I cannot see even with large printed materials. Can you help me with something? Then we will start with the magnifier, prescription. So that's how the process goes lah. So he came with no complaint one.
Because
Miss
I'm quite
Indira.
confused. If doesn't have any complaint, then visiting, it's time to just about to getting the baseline and waiting for the complaint started. Because for after I heard these cases, I just like confusing myself that what we can do on our side.
So basically, in low vision clinic, we solve the problem based on the complaint that patient has lah. Okay, if let's say patient is not complaining, then we don't catch out that.
Bother anything.
Yes.
I see.
Okay. Yes,
Miss Indira,
Okay.
do you
Yes.
give any letter to school?
No, because when he came to us, there's a time that that following week is the first day of school. So I told the mother that go to the school, look at what's happening because he is going to join the small normal school, ma'am. So I told the parents that you go send him to the school, you monitor for 1 week first. Oh, sorry, 1 month first. What are the problems that he faces? Then you list down, and then when you come for the second visit, which is supposed to be after 6 months, then you list down to me what are the problems that he faces, what are the helps that you think that he needs, and then I will provide a better one because he's shifting school. So the mother doesn't know the culture of the new school, how far the the whiteboard or blackboard from the chair, where is he going to be seated, or how is going to be his Pendidikan adjustment in class. So don't know anything about that. So I told the mother, you monitor first, then I will provide the letter. I mean, a complete letter rather than like give them bit by bit, give the whole thing.
Miss Iran, can I ask
Yes,
for
yes.
just now? You say that the large printing material, right?
Okay.
So means that every time, like for the children's use the original textbook, right? So need to go to the photostat copy, that enlarge them, or how to means that
Yes.
the
Yes. Okay.
because
So
original is original, right?
yeah, original is original. So
So
one thing to
parents need
do
to
is
prepare.
yes. Okay. Although it looks very troublesome, but that's going to make their life easy.
Okay.
Okay. Rather than prescribe them with a magnifier, going to cost them lesser, but then it's going to be trouble them for longer period. So rather than that, okay, what can be done is the textbook print in large materials. Like for example, if let's say it's a A4 size, print it to A3 size. Easier for him. Okay, and whenever there is a assignment given in a paper form from the teacher, similar thing. From A4 size, print it to A3 size, enlarged version. So that will help. Although looks very troublesome, but it's going to be very helpful for the patient.
One thing good about this is we were discussing about his near vision ability. The current stages he can only read quite a font size because 5.0 M. So we convert to N Norton, it's like kind of big size. So we making
32 right eye and 40 left eye, something like that.
Yeah, it's kind of big font size. I was making a joke while discussing. So, sooner and later he will need a architect paper like printed in one page.
No. Yes, for the moment we can still print it larger lah. Okay, and then we'll see like if let's say he's ready to use the magnifiers, or if let's say we can recommend him with the magnifier app and all that, he doesn't need that lah. Okay, he just need an iPad with a stand. That will make things easier lah. Okay.
One thing good about these kids is according to the clinician recorded, so says that his eye is actually improving. So it's like developing as well. So
yes,
hopefully to a better side, not to a worse.
Yeah. By the time he crosses the plastic age, right? We expect some improvement, but it doesn't happen to all people. Okay, but we are expecting it not to actually get worse, but getting better lah. Okay, but we have to monitor and see. Okay, so for the moment we just have to monitor lah. Okay. So this management, right? Okay, can you go to the management? Just a small doubt. Okay, this was what was done, is it?
This what was done. The below one is what we think of.
Okay, that's what we think. Okay. So just getting it.
Indira, just now you asked that question. Have you answered already?
Which question? Did I miss any? What question was that?
You said the visions. How will affect the vision for the right eye and left eye in future for this patient? What possible?
You just asked, but you got answer.
Yeah. You just like ask about these questions.
Did I ask? What did I ask?
Yeah,
what
left eye is the
asked just
peripheral
what
vision loss,
patients
or the
see
right eye,
when
or what?
right eye like this
Oh,
and left eye
okay.
like this.
Oh, sorry, I got diverted. Thank you, Alex.
Yeah.
Okay, So if you go to the right eye findings, Young Hao, can you go to the right eye? The findings. See, got diverted. Thank you. Pulling me back to the track. The VA first.
VA. Okay.
Okay. So based on the VA, right? Okay, the right eye VA is not good. Okay, compared to the left eye. Left eye is the better seeing eye lah. Okay, but then when patient using both the eyes, right? Okay, the vision is actually following the left eye VA, almost there. Okay, so when patient is looking at distance or when patient is actually looking at distance, right? They can read something that, or they can see something that is like 630 and above, should be no problem. So whatever that is smaller than that is going to be difficult for them. Okay, and also for near, whatever that is N40, then okay for them. Okay, whatever that is smaller than N40 is going to be difficult for that patient. Okay, and then when you look at the visual field, right? So the right eye is the one that patient has or not done, right? So we don't know. Okay, left eye is the one with the small lesion on the macula. That means this right eye is having optic atrophy, right? And left eye have some lesion in the macula. Correct, Young Hao?
That's right.
Yes.
Okay.
All right.
So the eye with optic atrophy, we can expect some visual field loss at the peripheral. Okay, and then the left eye, the one with small yellow lesion on the macula, we can expect some disturbance in the central vision. Okay, but when these both eyes are working together, right, they compensate each other. Okay, so compensate each other, and that is the reason why he has no prominent complaint. Okay, like bumping into things, or I cannot, when I read, I miss some words while reading. There is no such thing, because one eye is complementing another eye for peripheral, and one eye is complementing another eye for the central vision. So that's why if you see in terms of complaint, right, it doesn't look like the vision is affected much. Okay, so that's why I doubt whether whatever that he's doing, that like always want to be accompanied by someone and all that, could be his behavior is the one that leading to this, not the vision, because one eye is complementing the other eye very well. Okay, so vision wise, only the blurriness should be our focus when it comes to management, rather than focusing on visual field until there is a drop further in the visual field of both the right eye and left eye. Until then, we don't need to bother about that yet. Got it? This is what I want to actually, ask you to answer, and whenever I only ended up answering it. Okay, so this is the reason why the complaint is not so obvious. He has no major complaint, although the visual field is affected and the VA is affected, but the VA is, the major complaint compared to the visual field test. Okay?
Okay.
And in this 6 months, or okay, if let's say, okay, he came on February. Okay, if let's say you're gonna monitor him on July, or if let's say you monitor him, okay, supposedly if let's say someone monitor him after 1 year, you will expect some drop in VA or better or no improvement or decrement in the VA of the patient, and justify why. Anybody wants to answer? Hey, suddenly become so quiet.
Yeah, for me,
No.
For my
Group member don't answer. Others.
Oh.
Group member knows. Anybody wants to attempt?
I think the Mr. Man still remembers the angle, right? So due to the muscle.
So you are saying that the nystagmus will remain the same.
Yes.
Okay. Anybody else wants to comment on the VA, on the visual field? If you monitor him, okay, let's make it very easy. After you monitor him next year, February. What do you expect? The VA to get worse, no improvement, or better, or nystagmus gets better? Anything. You can comment on anything.
Before that, did patient wearing any glasses?
Yes, he is.
On that? Then
it's the
should
present.
be
Yeah, because there's a present RX.
then should be we are expecting remaining the same.
Okay.
Mm-hmm.
Because he's wearing glasses, so
Yeah.
should be remaining the same.
Unless the habit is not like it's not tend to like love wearing spec, then we can expect it like the VA might be dropped.
Okay. Anybody else? I'm looking for one perspective for you to answer.
Miss Instera,
Hopefully.
maybe the patient will be more because the right eye is 525 and the left side is high estate. Maybe the patient will getting the nystagmus will be it's not stable on both eye cannot work together lah. Maybe get confused on the vision
Yeah.
differ
No.
on right and left like that.
Correct. The question is, if let's say you monitor this patient, so you are saying the nystagmus will be the same even after you monitor the patient after 1 year.
Getting worse?
Will be getting. You think that it will get worse?
Yeah.
Why? Why you say it's getting worse? Now I will relate to the point.
Oh.
You say that after 1 year, you think that nystagmus might get worse. Okay. Why?
Maybe the right eye is getting worse, the VA.
Okay. You guess that the right eye will have a progression of refractive error, which will lead the nystagmus to get worse. Okay. Point.
Yes.
Okay. Anybody else? Some other perspective. If somebody asks question, need coffees? All face. Oh, this one is earlier mentioned. Okay. Will have tropia. Possible to have tropia? Oh, yeah, possible to have tropia. Other than that, justification. I want justification. Even for the tropia also. Why do you think you will have tropia? Which eye and why?
Hopefully the left eye won't become worsened due to the yellow lesion.
Okay, you expect the VA might drop because of the lesion. Okay, if the lesion progress. Okay, good. Other than that,
and
one more perspective. One perspective.
Patient are usually too shy and usually doing the near task and not doing the outdoor task. So the vision will be like getting used to it for the near. Then that's why the distant VA might drop.
Possible. Okay, better explanation is extensive near task will lead to the progression of myopia, which will cause the VA to drop. Okay.
Yep.
Okay, that's a point also. But one more perspective.
One more.
Yeah. Based on the patient's age.
7.
The axial length.
Axial length.
Axial length what?
And
growing.
Growing and.
Growing is the point, but okay, axial length growing. So
and pulling elongate and pulling and make the optic the atrophy even more worsens.
Okay, correct. One more. What happened from the age of 7? I mean, from you born until you reach the age of 9. The plastic age. That's another clue.
Stick. No.
Oh, you mean the ocular development?
Yes.
Power, definitely the power will still grow because the development of the axial length. One thing for sure, the power will definitely, there's chances to go higher. So in terms of VA, we might not know yet, but due to the what we have the current records here, ever since from the few months baby until now, the VA is not further developed on the right. So I foresee that the right eye will be stagnant, not going worse unless there are some other play issue happen. But the left, because of the lesion that might also through this development process, that might also affected the macula become worse. So I can foresee the left vision and not only causing the copia or nystagmus, that will also causing the double vision because of the too much of difference on between both eyes.
Anybody else have different opinion?
I think the active mechanism going to remain the same for the left eye because the patient is better seeing eye is a left eye. So you use the left eye more and cause the myopia to be increased in the after 1 year.
Okay.
You can the posture or the way that the kids movement change with this nystagmus problem?
Okay, that's my question. Is the nystagmus will get better or get worsened by time?
Normally the nystagmus will not get worse so soon one. Normally it's very gradually. Normally the nystagmus like my patient only 60 something only deteriorate a bit but still can try the 60 something nystagmus patient. So for this young patient 7 years old shouldn't be worse so fast to be maintained his nystagmus.
Okay, that's what you think. Other than that, anybody has other comment on this? What you will see after 1 year?
The left eye VA will improve because the patient is still in the plastic period, 7 years old. It might develop 2 years more, like until 9 years old. There's still possible to improve the VA. So in this period of time, we are very crucial to have a optimum refractive power prescribed to this kid.
Okay, good. That's the answer that I was expecting. Okay, thank you, Alex, for that. Okay, anybody else have any other opinion? What you will observe after 1 year of follow-up on this patient? Anybody else have other opinion? We already talked about nystagmus. We already talked about plastic age and also eye development. We already talked about axial length elongation possibilities. Anybody else? Any other point that we missed out? That you want to highlight?
Will it the retina thinning? Because by cell length longer.
Yes. Elongation of eyeball will lead to the thinning of the retina because of the pooling effect. Okay. Anybody? Anyone? Okay. Kalau tak ada, we
I might think
conclude.
about Topo.
Yes, Kelvin. No, it's okay.
I might think about the Topo some more for the curvature or the sort of things. Due to this is still young, then still any like the curvature of the cornea is whether too flat or too curved for the current moment and also in the future lah.
Okay. But that's a point, but that's not the concern in low vision clinic because we are not planning to insert contact lens yet lah. Okay, but that's a good point. Okay, out of the box. Thank you, Kelvin. Okay, so we list down one more time. Number one, okay, in 1 year time, whether the VA will get better or get worse. Okay, so the possibilities varies. Okay, number one, it can improve. Okay, in terms of vision, it can improve because they are reaching the plastic age and they are still in the development stage. Okay, so possibilities for the VA to get better could be this reason. Okay, and also the possibilities for the VA to get worse also there. Okay, so VA can get worse because of the changes in the optic atrophy because it's a progressive disease. So by time it will get progressed too. So when it get progressed, it will affect the VA. So that means all three possibilities are there. So we're just looking at the reasons behind it. If it gets better because of the development of eye, okay, and he's still in plastic age, that leads him to have a good VA in future. Number two, there is a possibilities for decrease in VA because of the progression of optic atrophy. Okay, and also because his refractive error is very high. Okay, 525 for the age. So we expect the risk of myopia progression is also there. Okay, so the elongation of the eyeball, okay, will actually make the optic atrophy even worse. It's already there. Plus, with the elongation of eyeball, it's going to make things worse and will cause the VA to drop. Okay. Number three is no improvement. Okay, that means no decrease, no improvement in the VA. Also possible if, let's say, this optic atrophy is already stable. Okay, and plus we control the lifestyle of the patient of not focusing and doing a lot of near work, limit the near work duration. Okay, that will enable us to make the vision to be stable. Okay, so these three all possible. So our job, okay, we don't want to, okay, our job is to not improve, but at least make it stable. So our point, okay, when it comes to management, when they come, in July to see you, one is to explain this, okay? Okay, we are not aiming to make your VA to improve, but we are aiming to actually stabilize the the VA. One is limit the screening time, give more exposure for outdoor activity. Okay, so that is the only control that the the kid and the parent has. Okay, other than that is all external factor which they cannot control. Okay, so this management need to be given. Okay, so please write down this group B. You have to be more alert during -1's appointment. Okay, because you write down the points. Yeah. Okay, that is VA. Okay, now coming to nystagmus. Okay, so nystagmus, okay, chances similar. Chances to get worse, chances to get better is that, or chances for it to be similar, because he's not having it all the time, correct? He's having it only when the eye is occluded. Okay, chances to get worse is similar like VA. Okay, similar like VA, but chances to get better is also similar plus the age. Okay, when they are given full correction, optimum 1. Okay, so when they are given full correction, optimum 1, there will be more stimulation to the fovea. Okay, that will lead to the development of fovea. Okay, because he's still in plastic age. So when the fovea develops, okay, the chances for the nystagmus to get, the magnitude of nystagmus to get better is that. Okay, so our next visit, okay, no, patient's next visit with us, we should focus on doing refraction and make sure that the prescription that was given to him is the optimum one. If it is not optimum, we have to prescribe a new one. Okay, so that nystagmus can be improved. Okay, because he's still 7 years old, ma. Okay, we still can do something to make things better. Okay, next is visual field. Okay, in next round, visual field we have to do for both eyes. Okay, Jerem and also Jerem for right eye and Emsler for left eye. If he can cooperate lah. Okay, because we already do Jerem for the left eye, so we just try to do Emsler for the left eye to get a clearer picture, because the lesion is at the center, at the macula. Okay, and for the right eye, there is no such thing. So we can focus on the Jerem screen test for the right eye, and we, if let's say we can get it lah, because the other day we cannot perform because the vision is so poor. Okay, so if let's say we can attempt, we attempt. If let's say cannot, then it's okay, because our concern is more to left eye lah. Okay, So that will be the visual field test. Okay, coming to Vicky's point on whether the patient possible to get, tropia or not, yes. Okay, high possibilities to get tropia because of the imbalance in the power and also because of the vision. Okay, because the difference between the right eye VA and left eye VA is huge different, yeah. So possibilities for the tropia to occur, to happen, to start is very high. Okay, but we see whether our refraction can make the right eye VA a bit more better or not. If let's say we still can pull that, then the chances is lesser lah. Okay, but high possibilities the left eye will have tropia. Okay. Okay, so that's the progression. Okay.
Left eye or right eye, Miss Indira?
Right eye is the worst eye.
Yeah, because just now I hear you say left eye.
Oh,
Right,
sorry.
right, yeah.
Yeah, right. Okay, and okay, one point that group B you missed to highlight on the discussion is should have asked on patching therapy. I know that it was not done for him, but you should have actually asked that, that you should mention that in the upcoming visit. They should be we should ask the parents whether he has done any patching therapy or not, or any training, when he was small. So that need to be covered in the upcoming, visit with the patient. Okay, another thing is I saw something written as color vision not compulsory or something. Can you go to that slide? Is Yong Hao still there? Yong Hao?
Discussion.
Yes.
Yeah. Discussion. 21 page.
Patient can differentiate or suggesting obvious.
In general, you can still
Okay,
draw
so
and differentiate color.
current in the previous visit we never do color vision test, right? Okay, so in the upcoming visit we have to do it. Okay, why is it important color vision test for kids? Okay, number one is color vision test is very important because that gives the idea of what's happening to the eye. If let's say we know that the patient is having color vision defect, that need to be informed to the school. Okay, because many kids are being affected for being lazy when they are not able to distinguish color in the school. Okay, or not smart enough. Okay, if let's say really this boy is having color vision defect, then the school has to be informed that he can't differentiate colors. So he shouldn't be penalized for that. Okay, or he should be treated, in a special way for this. And also to give the parents idea that, his color vision is affected. So in future, if let's say he wants to select science stream or art stream, okay, which will actually direct him to the, the job that he's going to do in the future. So that should be highlighted now itself, so that the parents know that he cannot do certain job. Okay, so color vision test is a must. Okay, to see how much it has affected him. Okay.
Just now you mentioned about the patching, so to patch the patterson eye, isn't it? Patch the left eye to use the pos.
I think for this kind of patient, alternate patching will help lah. I don't know, but I don't know whether they have done it or not. If I'm mistaken, no lah, but I couldn't recall that.
But his VA is very huge different. So
but when young
I
time
think
we
not
don't
so
know, ma.
convenient to do a patching, but unless it's like watching TV lah, okay, because it's big enough to see. I do not know. We will dig out further lah. So how's the distance on the TV?
No,
Because
Yang Hao.
according to his right.
No. I'm not the patching therapy. It's not that I'm going to conduct it, in the future. I just want to know whether they have done it in the previously or not. Whether any attempt was taken then, and that helped the vision or not. Because after this doesn't work lah. Because the difference between the VA is very it's very huge. But the history, whether they have done it or not. Okay. Okay, and
If there is a patching before compared to patching never done before, what do you expect on
Okay, at least
the
we knew
outcome?
what kind of therapy that was given to him. At least we have some history. So that will actually give an idea of what kind of things that he has undergone. And what is the, if let's say the VA has been bad all this time, because we can always get Dr. Sundar's, findings to see whether the vision is progressing or the vision is actually improving or the vision has been stagnant even after we have, they have done, patching therapy. So that gives an idea of how the optic atrophy is actually progressing. Okay, and something about A scan, whether to do A scan or not to do A scan. Okay, do you think after our discussion A scan is needed or not needed? Give me justification. Everybody, need or no need? Hey, silent already. When one person talk, then the rest will be like, will be like, like a chain, like a virus. Mr. Stephen, tell me, do you think that we need to do A scan for this patient or not?
His scan.
Hmm. Necessary or not? Here the group say that it's not necessary. It's okay. But what do you think? Necessary or not necessary?
Can do also to find out more detail about the patient.
Okay.
Time to try out.
You think can do? Okay. Anybody else? Necessary or not necessary?
The patient power keep increasing, maybe can use the scan.
Okay.
If stable, then I think no need lah.
For me, not necessary lah, unless we are investigating about the XL length for other reason.
Okay.
Because we are not managing the myopic control. In this case, we are more to his low vision. So obviously, air scan is more to monitor the XL length. Yeah, and also we did perform others OCT to see how's the macula. So we think that it's not necessary for this case.
Okay. Okay.
I think need to measure for like keep the data also because patient actually 7 years old, right? And also the vision is we need to keep the left eye more important. If like the XL length is out of normal range, then we can predict anything for the future.
Okay. The optic atrophy is only in one eye, is it?
Right eyes.
Right eye.
Okay.
Yeah,
Anybody else?
I think it's need to do lah for the the scan. It's important as long as the eye is stable. So we should do. Yeah, we should do.
Okay.
Or maybe we do on better seeing eye only.
Okay. Since the left,
only the left eye.
Left.
The bad eye is not our concern. Okay. 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 Based on the response, I give you idea. Okay. Okay. What you said is right. Okay. It is not necessary. Okay. Because number one, it is the bad seeing eye is the one having high myo, and that is not our concern anymore because our job is to preserve the left eye. Okay, so that is acceptable. Okay, whether to do it on the good eye or not, okay, can be done, but it is not necessary. It's not compulsory to be done because the power is very minimal. 050 only, right? Am I right, Yonghong? 050, yeah.
It's
it's
only Aztec 300.
Okay, so 050 only. So axial length is not a problem, but you have to remember, okay, this is applicable for other, since we are already in the topic, but it is applicable for other cases, like certain patients, right, they have optic atrophy on both eye, okay, and then they have like high myope, right? That patient compulsory to do a scan. Why? Elongation of eyeball is going to affect the optic disc. Okay, so when kid is like let's say the same age of kid but having optic atrophy for both eye, then for that patient it's compulsory too, because when this is growing affects the optic disc area. Okay, the optic nerve will be affected. So for that patient it's compulsory. For this patient, as you justify, not compulsory. Okay, so this one I thought I need to clarify whether when to do, when not to do. Okay. Thank you. Okay, okay, one thing is, okay, in management, right, it is not written about the one management that I did, but was not there. It's not written. Okay, number one is advice on schooling. Okay, when this kind of patient comes to low vision clinic, right, you have to, whether the parents ask or not, you have to advise them regarding the choice of the school that they're putting in their kid. Okay? Explain the pros and cons of normal school, integrated school, and also the blind school. Okay? And then let them decide what they want. Whether they want to listen or not listening to you, you have to let them know. Because many parents, they have no idea about the system in the school, how that will affect their education and also the psychology of the kid. Okay, okay, I'll explain now. Okay, if let's say a kid who's actually having visual impairment go to normal school, the advantage is he or she will be in the circle of normal people which he's going to face in the outdoor world or in the future. Okay, so that will train them that they have to go through some discrimination, so they will learn how to face that discrimination and how to cope up with this kind of people, how to overcome the problems. All they will learn in a normal school. Okay, for sure. Okay, because they are mingling with normal people since beginning. But there are disadvantages. The cons are, number one, okay, they will be discriminated to the maximum level depending on the school. Okay, certain teachers are very kind. Okay, they can be, they can give a special attention for the kids, but not all teachers will give attention. Not all teachers are concerned about these kids. This is not based on my understanding, but it is based on the experience that the parents shared to me. Okay, some parents very happy to send their kid, the low vision patients, to the normal school because they have a class teacher or subject teachers who are very helpful, very supportive to the kid, giving him or her attention, special attention, so that he get to learn like other people. Okay, certain school they're still questioning, kenapa nak hantar anak you dekat sini, ada banyak blind school, kenapa you nak hantar sini, susah kita nak jaga. That kind of teachers also exist. Okay, so so if let's say they get the first type of teacher, then it's good. If let's say they get the second type, the later one, then it's going to be difficult for the kid and difficult for the the mental health of the kid. And number four is the circle of friends that he or she is getting. Not all friends are going to be supportive and not all friends are going to bully him, but possibilities are there. Okay, it doesn't mean that if he goes to blind school, he's not going to be bullied. No. Okay, bully case happens everywhere, but the parents should foresee that this also could happen. Okay, it's very important for the growth of a kid, learning and also facing the challenges at the same time. It's going to be a bit overwhelming for the kid. Okay, so with the peer pressure, so all this will happen in the normal school. Okay, and then when it comes to blind school, okay, the advantage of blind school is they will have all kind of facilities will be provided to them. Large printed materials is not something new for them. It is not like only for him they have to provide that. Okay, they're giving to everyone. So in terms of that kind of assistance, they will have, the desktop CCTVs in the classroom. So whenever they need, to see certain things which is very small, like diagram or maps and all that, they can always use that. So facilities are tip top over there. Okay, and teachers are well-trained teachers for visually impaired kids. And also the school system, like, they will have handrails everywhere. Okay, even the pathways are all meant for visually impaired person, which they cannot find in normal school. Normal school is normal school. Sometimes they don't have rails also, handrails also in the staircase. So the students will struggle there. But when they come to blind school, right, it is properly built for visually impaired kids. So that kind of, the safety, their personal hygienes are all taken care well. While in normal school, they have to do it by themselves. They have to find their own way. Okay, so that will be the advantage of the blind school. Okay, and also you no need to worry about the examination extension and all that. It's like auto, implemented over there. The disadvantage is they will be so happy with that circle. So once they graduate, adapting to the real world would be difficult. This will be the mindset of the parent. He has been mingling around with the similar, problem people. So when he comes out, he might actually, have difficulties. Okay. So this will be the concern of the parents. Okay. But another perspective is, okay, only the schooling time they'll be mingling around with. This is another perspective for the same point. Okay, only in the school they're mingling around with the same people. If let's say once they're back, right, when they go out, balik kampung and all that, they will still meet with the cousins who are not from the similar background, who has good vision. So adapting to that, and then when go out to mall or go out to playground, usually the kids will get adapted. So similarly, same thing can be expected, to happen after they graduate. We don't know. It depends very much on the characteristic of the kid. So this is one concern related to the, blind school. Okay, another one is integrated school. You know what is integrated school? It's a normal school, but they have like a special building or special level, maybe, first floor, second floor, only for um, special population kids, visually impaired and hearing problem people. Okay, students. So they will be in that level, and they will be studying together. But for certain subjects, they will join the class of the normal kids. Like for example, math, science and all that, they will study together with their group. If let's say subjects like elective subjects, not elective subjects, simpler one like language subjects, right, they will join the normal class students. Okay, so that is the integrated school. Okay, so the advantages and disadvantages, the advantage will be there is a chance for them to learn with normal people and also with the same group as them. So they are facing both the same. So that will be the advantage. The disadvantage is the group that they belong to in the group is not all visually impaired. It is a mix up. Can be visually impaired, can be hearing problem, can be many other problems. So it's a mix up. So so that will be the disadvantage. Though they don't see similar problem people. So these are the things that you need to explain to the parents, because the parents doesn't know. Sometimes they only think from the one perspective. Or if my kid go to normal school, he will mingle around with these people. So when he graduate, when he finish his studies, he won't feel very awkward mingling around with normal people. Okay, but they also have to look at the cons, whether they can accept this. Okay, so this need to be explained, especially kids like Deshwant, who is very shy. Okay, we don't want him to ended up to be the bully case victim. Okay, so because if let's say most of our low vision patients are very, how do I say, very friendly, very bold. Although they're kids, right? They don't care about what people think. That kind of personality also we do have. Okay, so this is another personality. So advising the parent, let them think, let them analyze before they make decision is very important. Okay, because when they came on February, the next week is already schooling. So I didn't want to kachao them. Let them experience the first, 3-4 months, and then when they come back to me, then they know what are the pros and cons. Then when they come, then we can explain further, and they will understand better. That's why in the first visit, didn't speak about it. Okay, now you see the importance of it. Yes, huh? Okay, so please do pay extra attention when it comes to school-going student. And when you are going to do management and discussion with the parents, you have to highlight this kind of things, which is very, very important for the mental health of the kid. Okay, vision is one. Okay, another one is mental health of kids is affected so much. Okay, because of the small, small thingy that we think is not actually very relevant or important, right? But we have to actually alert the parents, okay, regarding this. Okay, regarding the OKU card, it was not mentioned in the management, right, Yong Hao? No, right? It's not in the file. No. I mean, in the file, did they have mentioned anything?
No.
You mentioned, but no, right?
No, we found not mentioning. So
Okay, and the parents, right? The mother was a bit hesitant even when she met me in Oasis, because they came for that, whether need to apply for OKU card or not, or do you have any treatment for my kid? So I already explained them there. Okay, so this OKU card, right? Because they were hesitant that if let's say I register him for OKU card, will he be labeled in future or not? Okay, this question everybody, all the parents ask. Okay, if I get a OKU card for my kid, will they be labeled or will they be isolated because of this? Okay, one thing that you have to remember when it comes to OKU card is just to actually prove to the government that you are OKU. It's not going to affect you in anywhere else. You're not going to be labeled as OKU card and will be isolated anywhere. No, it is just to establish yourself that yes, I am not like normal people. That's it. And because of that, government provides them with some help. That's it. Okay, it is not something that is being used in the public to isolate them. Nobody knows whether your IC is a normal IC or OKU. I mean, and you also have, IC with the OKU card. Nobody knows. Okay, it is something that is very personal, and it is only needed to be given when you are filling the formal, letters and forms. Otherwise, nobody knows. Okay, so parents shouldn't worry about this. Okay, regarding the OKU card. So this is also not mentioned, in the file because I already done it in the Oasis. Okay, anything else that we missed to discuss? Whenever discussion, I talk more, yeah, more like a class now.
Can we vision therapy to prevent the tropia to be happen in the future?
No, that's not our concern. Our concern is only to save the left eye. Okay, if let's say tropia happens to the right eye also, it's not a problem because that eye is not seeing anything. Okay, the vision is blurred, so that's not our concern. Low vision clinic, we don't do vision therapy. We only give training related to make the quality of life of the patient better. Nothing related to make the vision perfect, like original. No, that's not our concern.
Miss one question. So this is something of the process. So what if this case is hyperope? So if we wanted to adjust his power, I mean not to adjust, just lead him to less hyperope or towards a myope. So do we encourage him to do more reading? So like this kids are reverse. We encourage him to go far.
No, we don't do that. Okay, so whatever that you do, right, whether it's near work, whether it's hyperope or myope, right, doing more than what you're supposed to do, it's going to damage further. Okay, so we don't do the reverse way. Don't ask them
Even
to
for
do
the
the
normal kids also, what if some of the parents also concerned, I don't want them to have this type of rope. So what we can do?
usually
Does the reading?
No, we can't do that. Usually when it comes to hyper kids, right? Okay, usually they will have like for example, when patient is having high hyperope, if let's say we ask them to do a lot of reading, will that actually elongate the eyeball so that the power gets lesser? That's the idea. Okay, but what happen is for hyperop patient, when you do more readings, it's actually going to have accommodation related problems. So that will induce that. So basically, you shouldn't do anything more than what is required. If it says the screen time is 2 hours or reading time is only 2 hours, mere work is only 2 hours for kids, it is applicable for whether hyperope or myope similar. Okay, because if let's say this case you ask them to do longer reading hours, it will elongate the eyeball for myope. If let's say hyperope, that will cause another problem like accommodation and all that. So we don't want them, convergence will be affected. So we don't want them to go to that zone. Okay, that will further complicate things.
They have
Those I
a
know that
accommodation problem, like
Sorry?
accommodation access or accommodation lack, that type of thing.
Yeah, like patients who are high hyperope, they tend to have esotropia and all that because of the accommodation is high. Okay, so possibilities are high. So there are therapies for that. If let's say they're high hyperope, how to control, that one is different. The one, it's a different pathway of managing. So don't mix up with the myopia progression and that idea to this.
That's why usually power will induce foria or tropia. So mostly we will address to the tropia and foria first. But that back to the power. So even they're given a corrective classes to minimize the tropia or foria. So do we still encourage them to do more reading? That's my question.
No, we don't.
No lah.
No.
Okay.
It will reverse some other problems.
Because we were talking about this plastic age. So I am thinking that that often having this question, how do we minimize even the short sight also we have a way of controlling the
if
and growing of this.
Hyperope means the full correction is the only help. Give full RX, the optimum one. Okay, if let's say patient comes with tropia and all that, then it's a different way lah. We give high plus lenses, you want to give others. But when it comes to hyperope patients, optimum power, if let's say tak ada apa-apa masalah lain like tropia and all that, then optimum power will help them to control the refractive error from getting worse. Okay, like myopia, we have like progression and all, myopia progression control techniques and all that, right? For hyperope is this.
Something we can do it. Only go as natural.
Yes, correct. Don't complicate too much for that. Yeah. Okay. Any questions more? Any discussion? Anything that we missed?
Bifocal for like to improve the near vision for the low vision.
Okay, when it comes to low vision, we don't prescribe bifocals. Okay, reason why is low vision, their vision is very poor already. Okay, when you give something like magnification, right, like high power for their reading and all that, okay, it's going to be very heavy for the patient. Distance also got power very high, near also got power so high. So that is actually going to cause them problem. And also the transition of, from the top to the bottom, it's actually causing a lot of problem for them because they are not only having problem because of refractive error, but some other condition in the eye also. So usually never. Okay, it's either single vision for distant or single vision for near. There is no multifocal, bifocal in the vision clinic.
So do we encourage them to wear two separate glasses, one for distant and one for near?
Yes. We are not, again, I'm coming back to the point, is to make the quality of life better. Able to do the task that, whatever task that they are able to do with whatever correction or devices that we give. It's not making their lifestyle like normal people. That is not our aim. Our aim is with this near glasses, you should be able to read this. With distance glasses, you should be able to do this. Okay, I cannot give you a multifocal for you to use computer. For computer use, I'll give you another glasses. Okay, so cannot combine. It's very difficult with their limited visual field. If let's say they have central scotoma, it's going to make things even more worse. So bifocal, multifocal, no, a no in low vision clinic. Lagi? Ada? Okay, if let's say tak ada, then we will end the session. Okay, just a reminder, yeah. Okay, okay, good presentation, first of all. Okay, although the case is very limited, but I like your discussion part. Okay, because you don't have much information for your, for the case, but your discussion part, this 4 slide is very interesting. So I like that part. Okay, thank you so much for that. Presentation wise is good. You understand your case well. Okay, so have no major, and able to answer question. So participation for today, there are some people still never open mouth today. Okay, I have actually noted down that. Okay, and one more thing is, okay, so we are done with this. Okay, now next is regarding your geriatric clinic, yeah. Okay, so geriatric clinic, okay, don't take long time to submit the case. Okay, your recording and all that. Okay, try to make it within 1 week. Let's say today you have clinic, next week by Monday you try to submit. Okay, if you drag too long, right? Okay, even the supervisor also will actually, don't know what happened on that day. They have to go through back the YouTube link and all that lah. Okay, so if let's say you can submit early, then it will be good for them to, track you lah, easier. Okay, so please do submit within 1 week. Okay, and also there will be some supervisor change. Okay, which we can expect very soon. We already interviewed the external supervisor, Miss Gita, which I told you last week. Okay, so most probably she will join anytime within 1 or 2 weeks time. So after that, she will take over almost all the clinics for geriatric. Okay, so that's the update for now lah. Okay, so that's the only thing. Reminder: submit within 1 week. Okay. Okay, and then we have there's one group having geriatric clinic in the afternoon with me at 2 o'clock. Okay, I will see you. I will give you the link. During lunch hour. Okay, so I will settle some things and then I will send you the link in lunch hour. Then you can join like last week lah. A new link. Don't go for the old link. With me, every time you have session, I'll go for a new link because it's easier to track. For me, if let's say I missed out to, upload the wrong recording, right? It's easier for me to actually track down. So with me, every time we add a clinical discussion, it will be a new link. Okay.
Okay.
Okay, all good, yeah? Okay, thank you. See you all in the
This is
afternoon.
Indira, sorry.
Yes,
I have one
Benjamin.
question. Regarding the geriatric section, before we submitting the form, do we need to attach the YouTube link? The
It's
supervisor
okay. It's
video
okay.
link?
No need.
It's
We
okay,
have
don't
the
need,
link.
right?
We
Okay,
have the
okay.
link. We can always watch. If let's say it's your supervisor already uploaded the link, then you put the link. If
Okay,
tak the link, but you can always update the file, right? Can?
Don't know.
Oh, then it's
I
think that's
difficult.
my
Can
Cannot,
just,
another
just the
question
file
for
will be
me.
duplicated.
Wait. Let me settle Benjamin first. If let's say if let's say you cannot upload the link, right? I mean, you cannot update the file. Can you update the file once you already?
No.
Now
Have to
is a,
submit the new one. That's why I send message for asking delete the old one, right?
Oh, then you have to have the link lah. Otherwise,
Unless Miss
MQ
Indira give the permission for us to like arranging the file, then we will be able to do that.
arranging file means what? What?
Because SharePoint got two functions. One is like only controller can editing all the file
Oh,
inside,
I put there can edit, you know, but you all
but
cannot edit,
we
is it?
cannot access.
Yeah.
We only can
Because
do the uploading.
I'm delaying submitting the form because there's no YouTube link there. Yeah, I don't know whether have to attach or don't need.
Yes, you have to attach that because
Yeah,
otherwise, you
that's
know,
why.
we open the file, right, without the link, then if let's say we have MQ visit, then they will query that. Why no link? Then how do you assess? You know, ini tipu ke betul ke? There'll be a problem lah. Okay,
But till
so
now
then
our
if
session
let's say,
still don't have lah.
Wait,
okay, then you have to wait lah.
Wait, I think we got the link right for you click into the SharePoint.
Boleh ah.
On the 9, we have a link for 3 room. On the 10, we have 3 room link as well. On the 12, Mr. Lawan not yet. Mr.
Okay,
Lawan
so
not yet.
if let's say you have to wait for the link, then you have to wait lah. Then there's no issue because it's the supervisor who are dealing it. Okay, supervisor who are updating it soon, right? So ideally 1 week. If let's say you're not getting link, then it's okay.
All right.
Okay, so your supervisor is also not free to check, right? So tak apa. So if let's say your supervisor already upload link, within 1 week try to upload the recording form lah.
Okay.
Okay,
Sorry.
Okay, yes, Alex.
Can we have a standardized file with name for upload the geriatric form?
Wait, let me open and see what you're uploading now.
Like we need to put a patient name, or we need to put our name or the supervisor name, like that.
Put the session. Okay, those who have uploaded, no problem. Okay, those who are going to upload after this, you just put the name of the patient and your date and time.
Date and time.
Okay, for example, my patient is Jennifer. Jennifer 16/16 9 to 1 p.m.
Oh.
That's it. Easier. So that when I go through this, it's easier for me to track. And okay, oh yeah, supervisor is also different, okay? Underscore IM. That means I supervise you lah. So I supervise, okay? That means I check Jennifer on 16 June. My session was 9 to 1, supervised by IM. Got it?
So means no need our name lah.
No need your name because the folder is your name, right? Okay, I write down here. Patient name, date, month, time, underscore, Aswini. All huruf besar. Thank you for the idea. Thank you, Alex, for suggesting that. Correct, capital letter. Boleh? You check the chat. All huruf besar.
Okay.
Okay. Yongha wanted to ask me something, but keep disrupted.
No worry. So I was wondering, because like this live section, so after we dismiss, so usually in this we call the share team, the teams the members of team should have the videos on that. So whenever I try to review back and try to click in, there's not accessible.
It's not there.
Is there any reasons? It's there, but we click, but because we are not able to access, so it says that we are out of the account.
Do I have to make the setting like that, is it?
I have no idea. That's why we previously all this we especially clinic we go through Zoom, because Zoom we will need to convert ourselves. But this team seems like recorded from the lecturer side. I mean the controller side.
Okay, then I will upload lah. If let's say you cannot view, right? Then every time we have session, then I will upload in the. You can see the link in the same share folder. Okay, they have LV geriatric session, right? Okay, so I have listed down, kan? Wait, let me show.
Actually, they have a live link inside the folder already.
Oh, really? I am very bad
Uploads
with
from
this.
some lecturer already lah.
Okay.
So I'm not sure whether it's the lecturer itself, they're gonna do it manually or there's
That's why if let's say I need to find out, maybe I can check with others. Then we can. Then I will do the changes. If tak boleh, I upload in YouTube lah, like usual.
Yeah, because it's easier for us. Sometimes we need to review back what we have missed out, and then we want to recap back what are
Sorry,
the
sorry. The setting is not allow us to do our recorder, right?
No, you cannot. This one memang you cannot record. Only I can record because it's my account. It seems. I mean, memang Segi made it that way lah, so that it is not being exploited or something. I don't know. So if you go to your geriatric,
yeah, never mind lah.
If you go to your Excel sheet, the weekly schedule, kan? The LV case discussion, weekday time lecturer presenting group, I will add in the YouTube link. So every time we add, I will upload and I will share it here lah, so that you can view. If let's say this is not shareable automatically, then I will do it lah. Boleh? Easier for you also lah. If you whenever you want to see, you can just go to this page and then you just can click. Okay, yeah? But this session, just give me time because this week is clinical exam week. We are fully packed with our.
Just want to share. Want to share. Yeah, actually, we can use our Teams, Microsoft, SUKD account to record.
Oh, really?
Yeah, we already done before, but we need to have two accounts. One is Segi, one is personal for the login for the Teams.
Oh. Okay, never mind. I'm doing the recording anyway. We have to keep record. Then I'll just record and upload lah. Easier for you. Okay, so that no need individual recording lah. It's going to be troublesome for you, kan?
Miss Emilia, for afternoon section live, you will send out the link, right?
Yeah, nanti lunchtime I will send. Can ah?
Okay, thank you.
Okay. Okay, thank you so much. See you all. So last week after I update, was the session up to 12 o'clock? The geriatric clinic? Who did? The previous clinic with whom you had?
Previous clinic. Yeah. You already sent the link.
No. After that tak ada clinic lagi. Okay lah. 12 June with Mr. Lau. So did you discuss case Benjamin and Alex after the session with Mr. Lau? Yes, huh?
Yes.
Okay, great. Okay, see you all in the afternoon. Who will be afternoon? Benjamin, Mr. Steven, Ting Woon, Kevin, and Swetlin. Okay?
Yep.
See you all. Bye-bye.
Bye-bye.
Okay.
Thank you.
Bye-bye.
See you later.
Bye-bye.
Thank you, Miss.
Thank
Bye.
you. Bye bye.